Hey everybody, thanks so much for tuning into my presentation tonight. Um, the title of my presentation and the disparity that I'm going to address in the public health realm is mental health disparities between rural and urban Americans. Um, and it's really an overview um, of the general problem, the legislation that's currently been enacted by the federal government, state governments, and other policy institutes, and the general solutions that I think it can be integrated into the overall framework as well, into the Healthy People 2030 framework, and in general to problem solve this, what we call the silent epidemic in the United States. Okay. So the first slide here is just going to do an overview of the rural mental health crisis and the mental health crisis in general in America. Um, so it's a pretty large topic right now amongst the general public. It's commonly discussed in the public policy arena, but the state of mental health in America really is in peril. Um, Irrespective of the particular population that's being affected or the condition that's under discretion, really, you have about 22% of adults experience mental illness each year. That's 1 in 20 adults have a serious mental illness, and suicide is the second leading cause of death for youth and teens that are aged 10 to 14. 17% of youth aged 10 to 17 actually experience a mental health disorder. And as we know, COVID has only exacerbated kind of the severity and the disparities that exist in this realm. There's many factors that have affected each of the populations and demographics in a really intrinsic way, and there's a lot of structural inefficiencies and inequities that exist that have kind of forged the road to where we are now. But with that being said, one of the big focal points of our class was the dissection of population-based healthcare and the capacities by which population health can be managed in a healthcare system, and what are the effective means of doing that for advancing the health of a population, right? So obviously we're focusing on rural mental health disparities that exist between rural and urban Americans, and rural Americans are faring far much worse, right? So Americans that are living in rural areas already experience an incredibly high rate of suicide and depression, more so than those in urban areas. In fact, like you can see on the screen, it's about 1.5 times more, and are far more unlikely to access mental health services. Suicide rates between urban and rural Americans are pretty disparate. You have 18.3 to 20.5 per 100,000 Americans or citizens in that population in the rural group, and then 10.9 per 100,000 in the urban group. And suicides, the rate has increased at almost 48% in rural areas in comparison to 36% in rural areas. So somewhat comparable, but still different. And just those living in rural areas are experiencing just a lack of ability to access mental health treatment. The providers are often less highly trained than those compared to in metropolitan areas. So two age groups that I think are particularly affected, which is kind of the advent of the new age of technology and social media and other forms of technology that really isolate individuals and cause other issues within the mental health arena, are the 10 to 14 age group and 25 to 34. Suicide rates are almost 4 times higher than that for adults that are older than 34 years old. And then you also have another really vulnerable population in older rural adults, especially men, that are very at high risk for suicide. This is probably more that's contributing to that, is that there's a lot more veterans that are in rural America that die by suicide each year. But even with all that being said, as is the case with any medical specialty, we really have to take a holistic approach to kind of analyzing what the issue is, and the factors that are kind of like promulgating the disparity from a biopsychosocial model approach, right? So in our presentation, in the research that I've done, the factors that are the most critical in contributing to this disparity are the fact that there's a lack of access to psychiatric providers. The economy in rural America is very fragile in many ways, so we'll get into that a little bit more. And there's a lot of social stigma that surrounds rural American culture, which we'll explore in the next 15 to 20 minutes. Okay. So first one, lack of access to psychiatric providers, right? So rural residents have to travel incredibly far in comparison to their urban peers to access equitable mental health services. There's a lack of public transportation or limited access to private transportation a lot of the times for economic reasons. Sometimes people don't have, valid driver's license depending on the demographic. Fuel's expensive, and then just sheer lack of time. Those are really important barriers that inhibit rural Americans from accessing equitable healthcare, mental health care. So primary strategies that have been used to address this, disparity in rural areas have really been to provide economic incentives and training in rural settings. So that was like the initial incentive, which can work, but it hasn't been shown to actually create any sort of traction over the long run. So in a study that was done, a retrospective analysis of National Healthcare Services alumni showed that 60% of alumni are in service to the underserved population of up to 15 years after their service is completed, but only half of those 60% really stayed close to the original service site. And yeah, right, that's just one factor, right? The sheer shortage of psychiatrists, mental health clinicians, mental health counselors, psychologists, and other therapists is due to the fact that there's not much public funding either for it, which is changing now as of 2023. There's lower reimbursement rates, and the fact that rural Americans also have a lot of times lack of good insurance that will actually provide networks for them to be able to access these services. So they have Medicaid. Medicaid typically only reimburses providers about $60 to $70 an hour, whereas private insurance or private pay is over $120 per half hour. So providers across the country are transitioning to this model for their own monetary benefit, right? And I think we need to do more to allow access from solely an insurance perspective. Another huge component contributing to the disparity is economic fragility, right? So the economy being really fragile in rural America. So people living in rural areas have to pay much higher out-of-pocket costs if they want to access equitable service, on top of having to drive really far or commute really far. This really puts a patient in a difficult situation, right? So it's like oftentimes they can't access care. Well, do they choose between food, or do they choose between healthcare, like mental health services? And we never really want to put a patient in that kind of a situation. That's just immoral and an injustice on the part of society in general. There's a much higher proportion in comparison to various other people living in poverty or below the federal poverty limit in rural America. In 2021, the income for all Americans was about $64,000. In rural America, the per capita income was about $50,000, with poverty being about 15.4%, and in rural America, and it's about 12.8% nationwide. There actually are some counties in rural America that have over 20% or more of the population in the county as being below that federal poverty limit, and that figure has really only been growing over the past 3 decades. So poverty in general, we're not going to talk about it too much, but we know that poverty in general leads to insecurities that are related to food, basic shelter, and access to what we call baseline level of healthcare. So if you think about it, like the degradation in one of these categories leads to like this level of criticality that can cause a spiral effects that cause adverse health outcomes, right? And that's why people who are in poverty suffer poor or greater degrees of poor health outcomes. And within this category is mental health struggles, which is probably promulgated by the fact that there's elevated level of stress because you have to deal with these stressors, right? So people who are in poverty often deal with having to get basic life necessities with the means that they have, right? And so intergenerational poverty is also a major issue. It's causing intergenerational mental health crises, which are now being documented. Children are exposed to environmental stressors that are kind of a subsidiary of living in poverty, with having food insecurity, parents having to work multiple jobs and not really being able to support them. So all these factors contribute to an increase in mental distress and really a higher predisposition to trauma, which is a major contingency factor leading to mental illness. Another one of the big points that I touched on in the intro is the social stigma component. So rural Americans just experience, and it's due to the nature of the community, a very high level of insecurity when it comes to seeking psychiatric help. There's a disproportionately higher rate of adverse mental health stigma, which is a driver of them really being inhibited to seek help. So limited health literacy is also a really big challenge in rural communities, right? It impacts their awareness of their mental health condition and what their treatment options actually are. And their perception that there's this like lack of privacy is something that's mentioned a lot by rural residents in a lot of surveys that are done and qualitative data that's been collected. And people generally be averse to seeking help if like their anonymity or it's not anonymous, right? I think most people actually would feel that way. So, rural Americans have interconnected social groups, which drives that. But that also means that we need more culturally competent mental health care and mental health providers that understand that, right? So, while, you can fix the volume that's prevalent, if you don't diversify the workforce from a fundamental standpoint, you'll have more people that just can't provide the highest level of care that aligns with the beliefs, the practices, the culture, and the backgrounds of people that are seeking mental health and healthcare in general, right? So we know that the biopsychosocial model is integral now to ensuring that people actually have high quality health outcomes. And this is actually even more interesting because rural America has become exorbitantly more astronomically more, not exorbitantly more, astronomically more diverse in many ways, which amplifies the need for culturally appropriate mental health services. So I think what our public agencies can do is drive communication campaigns that are focused on this like positive reinforcement on educating the population on mental health services, with the focal point being like kind of the normalization of mental health treatment. People really need to feel validated about what they're experiencing, and the population is suffering already from the lack of a diverse workforce. So public campaigns could be very beneficial, I think, for validating the experience of Americans and really kind of breaking the mold of social stigma. And so there's a ton of disparities as we've already touched on, but our nation is becoming increasingly more diverse, and this kind of builds off the last slide. People of color on average experience a higher rate of adverse mental health outcomes, along with a plethora of barriers to care, which I kind of had previously discussed. But the current demographic amongst mental health providers is largely white, right? 86% of psychologists are white. 70% of social workers are white, and 88% of mental health counselors are white. So that's massive in considering how diverse America is. And much can be done from a policy perspective to improve the diversification of the workforce, such as creating job opportunities that are focused at the community level, recruiting students from communities that have the greatest need for representation in the mental health workforce. While research has shown for a long time that ethnic matching, which is pairing a patient with a therapist based on race or ethnicity alone, is not always effective, and we get that. But that technique is equivalent to saying like a white client can connect with any white therapist, right? And people of color and of underrepresented minorities in the mental health profession should be available to the extent that like people of all backgrounds can access or select a therapist that they feel best meets their needs, right? And I think by investing in a more representative mental health workforce, people of color can really partake in more choices for their healthcare, right? Not just sequestering people to have to work with somebody who they think there is a bias potentially, or that they don't really understand them. But another like major dilemma faced by people of color, racial ethnic minorities, that and which I had touched on, is really the part of poor insurance and the poor insurance is what another point of like diversity is that a lot, we don't diversify the insurance marketplace enough to give access to a broader span of mental health workforce. So what I mean by that is somebody who maybe lives in Lincoln, Nebraska could potentially get access to health care abroad if there was a more diverse set of mental health services, or if the expansion of telehealth services was still prevalent, which it has been reduced at an incredibly drastic rate ever since the COVID mandate had kind of diminished. So moving on, slides 7 and 8 are really combined. So I'm really going to talk on slide 7, and I might move to slide 8, but it'll be posted for your reference if you want to kind of follow along that way. So current policy is such that like the Biden administration has really been at the helm of trying to rectify many of the injustices and many of the injustices going on with rural mental health treatment. So the CMS says that in general there needs to be more outreach to rural Americans within the marketplace for the Affordable Care Act. So they had spent $5 million conducting a rural-focused outreach, and health insurance enrollment activities were included in this during open enrollment in 2023. And really a lot of the resources that are generated will be used to conduct like mobile and virtual outreach in rural communities that offer in-person appointments in more rural areas in general, which will help to reduce those barriers that are faced by having to drive long distances. There will be a lot more enrollment assistance. And this was also in addition to the $98.6 million in the Navigator funding available that was put in for 2024, which will be really interesting to see data on, which will help consumers kind of understand what the new coverage is and help them curate their health insurance plan to meet their needs, right? Another big initiative was value-based care initiatives in mental health. So the Medicare Shared Savings Program, which some people know about, but it's kind of like an arcane, ominous area. But it encourages providers to basically join accountable care organizations. It is quite expensive to form an ACO, and there's a lot of necessary investments that often need to be provided to create like an integrated care system, which I'll speak about. But CMS said as of January 1st, actually 2024, they're going to provide upfront payments to certain ACOs to help them expand, especially rural ACOs, into these communities. And like they could really use that money for staffing, hiring community health workers, investing in the infrastructure such as like EMRs to be more integrated and to manage a lot of the social needs that are prevalent with Medicare patients, such as like food insecurity, especially ones that don't have like another part or a another like subsidiary or like a Medicare Advantage plan. But also if you're going to invest in the healthcare workforce, diversifying it, growing it, Medicare also said that they're going to expand resident training. So like 1,000 new training slots for medical residents, which is going to be massive. That's 100 slots specifically designated for psychiatry by 2026, which is pretty big, and that was part of the Consolidated Appropriations Act of 2023. And HHS is going to do a lot more additional outreach and have technical assistance provided to rural hospitals to encourage the increase in applications. The Department of Health and Homeland Health Services awarded $11 million to the Rural Residency Program, Rural Residency Planning and Development Program to establish these new residency programs. There already have been a ton of physicians that have been trained as psychiatrists through that. And then there's also going to be physician assistant training in behavioral health, which will be massive because that's not as common of a specialty, which will help to really expand services. And then the last point that I really wanted to touch on was, kind of the integration of this integrated behavioral health or integrated care, which is combining primary care with behavioral health, which will help to facilitate the screening process and then transition to right in the office with being able to refer a patient who screens poorly or is positive for potential mental illness predisposition right to a behavioral health clinician. All right, so that's like slides 7 and 8. So please take a look at the next slide as well. All All right, guys, so this is slide 8. As I had said on slide 7, it's kind of a combination slide. Please take a look, but I didn't want to jump around. So I'm going to go to my last slide now, which is kind of the integration of everything that we've talked about into the Healthy People 2030 framework. Okay. So to be included in the Healthy People 2030 framework, it starts with the proposition that mental health care, and especially rural mental health, which is what we're talking about, and the disparities that exist, have to be a core objective, right? So core objectives are really comprised of like these work groups that are made of subject matter experts that work for the federal government. And then most of the Healthy People framework objectives measure progress towards a target over time, but obviously there's some limitations to that. But after something is identified as being a core objective or a developmental or research objective, which the mental health crisis should be identified as, we can begin to identify what we know as these leading health indicators, which really then track data, measurable data over time. So the reason why I think there's such a high correlation, or would be, between having this be a core objective, having leading health indicators, and then having seeing the progression or positive growth in like rectifying the issues with mental health, is because leading health indicators follow a model, right? So they should be structured so that they focus on upstream measures like risk factors and behaviors, which a lot of the data and evidence-based protocols already do. And then they have to rely on social determinants of health, health disparities, and health equity, which is a major component of what we're talking about as being like the most critical for rural mental health disparities, and having those policy initiatives that will really benefit that, especially in rural mental health care, which is so predicated on like a biopsychosocial approach, not just treat the disease, right? It's much more, there are more factors that impact it a lot more, as we've discussed. So in kind of like summarizing the entire presentation, the disparities that exist between rural and urban Americans, are massive. It's very prevalent, but ideally it fits into this model of the Healthy People 2020, Healthy People 2030 framework. But creating rural mental health as a core objective will just create this more national scale. It'll increase funding from a federal, municipal level, and I think it'll really help for funding and to solve, hopefully, what is been unsolved in America's silent epidemic. All right, so I want to thank everybody for listening to my presentation. I enjoyed speaking to all of you, and I hope that you've enjoyed it as well. Please feel free to follow up with me if you want to talk about it in any way, or if you have any questions. Okay, I look forward to hearing all your presentations and working with you throughout the rest of the program.